And thanks very much, everybody that's here today and also online. So Alex and I are going to do a duet today, and I'll start off first.
We're definitely not singing.
We're not. So the first thing to say is that this has been an amazing journey, and it's something that we can't achieve together. We can only achieve when working together. And these are a list of people that I want to acknowledge, particularly the patient representative, but a whole range of other colleagues who've been with me from the start, and some in much more recent time, other pediatric endocrinologists from across the country, and also we've now recently had endocrine nurses on board. So we engaged in the whole process from the start in 2019 with a survey of current bone and endocrine practice in relation to the 2018 International Standards of Care, and were at the NorthStar Standards of Care meeting in 2019. And what we've achieved so far is that based on the 2018 International Standards of Care, from the working group, we developed a set of guidelines which we think are standards which should be minimally implemented in the UK, but specifically with the issue of adrenal insufficiency, which was not addressed in the International Standards of Care. We developed a recipe of guidance for oral sick day stress dosing. Some of the other information leaflets have been developed and webinar, and the process, which is very similar across all the working group, is a working group developing this UK-specific standards of care based on the international standards of care, wide consultation with patients, with neuromuscular clinicians, but also other professional bodies, and it has been all endorsed by the Clinical Committee of the British Society of Pediatric Endocrinology and Diabetes. I'm not going to go labor through this guidance, but these are in brief the guidance that we've developed, and it is on the DMD Care website. We gave much more nuanced plans for adrenal insufficiency, and this includes a oral stress dosing. So other work that we've actually performed since is we've also sent out a steroid stress dosing survey to the patients, and I think Alex is going to mention some of the results in her section. We've also were keen to present this project and also our output to different professionals, not just specialists. And you can see that some of these stress dose survey, the bone and endocrine sections of the big family survey have been presented in various different conferences and nationally and internationally, and highlighting the project as well. And these are some of the outputs which have already been discussed and shown. And I'm going to pass on to Alex for now.
Thank you, Jared. So we actually in 2021 carried out a patient survey with the community. We wanted to learn what they thought about all the different aspects of the care, and I'm going to present some of the bone and endocrine results. There was about 164 respondents. The age range was from 2 to 46. There was a median age of 11, and about 20% of the respondents were over the age of 18, and 40% were non-ambulant, and they were actually seen at 36 different sites across the UK. So with regard to bone, we found that 16% of the respondents were not having their vitamin D levels checked. 37% had never had a lateral spine imaging for vertebral fractures, and 12% were actually monitored less frequently than every 3 years. 18% had never had a DEXA bone density scan, and again, 8% were monitored less frequently than every 3 years. On puberty, 6 of 62 respondents who were adolescents had not received testosterone therapy, so we've only got 10% of respondents on testosterone. So I did want to talk a little bit about adrenal crisis, and a mum who got in touch with me, Sharon, whose son Josh had quite a bad incidence of adrenal crisis. So a week before his bisphosphonate infusion, he had undergone surgery to place a port, and she thinks in hindsight he'd had too many procedures too close together. And he came home, and after the infusion, he went very drowsy, but was talking very fast. And she at first thought was actually to put him to bed and put him to sleep, because she thought he was just a bit worn out. but actually she was lucky that she'd spoken to the endocrinologist and knew what adrenal crisis was and took him to A&E. In A&E, the staff didn't understand about Duchenne, steroids and adrenal crisis. And she said it took a lot of time for Josh to recover. I think the point she was really keen to make is she felt there was quite a lot of lack of coordination between the neuromuscular team, the endocrinologists and the clinical trial team, because he was having the port for a clinical trial. She thinks that has changed now and there's far more coordination between the different teams. So what are the points? Yeah. Okay. So adrenal crisis, we know, is not common, but when it can happen, it can be catastrophic. And I think the patient community don't want another case like PJ Nikoloff, where the young man sadly died. So we do ask that every patient on steroids is given an oral 6-day and injection stress dose plan, that patients are provided with appropriate education and training. The data from the survey actually shows that if patients are given this education and training, they know what to do and they feel a lot less worried. Some of the concerns from within the community that some of the neuromuscular teams have actually never discussed adrenal crisis with the patients. A lot of people wrote that in the survey. We would like adrenal crisis to be discussed at every clinic appointment. I think with families, repeated information helps. And ask families to make sure if you do give an injection hydrocortisone pack that it is in date, because they do expire. And we've had families who wanted to give the injection and they've come to give it and it's been out of date. We found that in the survey, just under half of patients who responded had got injection packs, which I actually think is quite high. But then I do sometimes think the people who have responded to these surveys do tend to be the parents who are more engaged and perhaps have pushed for packs. We've asked that, I don't know if this has been done, but could it be added to the NorthStar checklist that it has been discussed with the patient, and so that it does happen routinely. We found that there were about 12 different steroid stress dosing regimes available that were given to patients, and I think this does cause quite a bit of confusion and anxiety over which sites are doing it right, which sites are doing it wrong. Nobody is, but I think just the range of recipes does cause confusion. So I think the patients do want education on this issue. Is there the possibility to set up ambulance alerts? So that it is flagged that the patient is a steroid user and does need to be given extra steroids. And I think, as been discussed a lot yesterday, education of A&E staff on the issue, so that families aren't begging for their son to be given extra steroids. They know that that's needed. So in conclusion, what's important to patients? We want bones to be monitored well and systematically, regular vitamin D and calcium checks, clear advice on adrenal insufficiency and adrenal crisis, discuss puberty at checkups, open discussions about hormone therapy, the pros and the cons, and to be seen promptly after a long bone fracture. I think areas that could be improved, there's currently in some sites long waits for DEXA scans and x-rays. We need clear guidance, especially with adrenal insufficiency. We don't want disjointed care between clinical teams. Endocrinologists to discuss the pros and cons of hormone therapies, as some do not even want to discuss this with families. And long-term steroid users would like routine endocrinology reviews.
So that's me again, and just to mention that the last two slides that Alex presented were in fact free texts provided by carers from the family survey. It's not stuff that we came up with or what Alex specifically came up with. There were a whole lot of free texts, and we summarized those themes. And what I thought it would be useful at a group like this, but also at a local level, that these are important patients' voice for us to reflect on service planning. And I think there are important themes there. So my next few slides really just talks to us about the next phase of what this working group specifically aims to achieve. We're hoping to publish the adrenal insufficiency guidance, specifically because the 2018 International Standards of Care does not address the oral stress dosing matter, and that's currently in preparation, led by Dr. Hashini Katagampulo from Great Ormond Street. We have given some guidance on oral stress-based dosing in adrenal insufficiency by DMD Care UK, but just to highlight to this audience as well, just in November 2022, initiated by NHS England, the British Society of Paediatric Endocrinology and Diabetes have launched a UK national guidance of management of adrenal insufficiency. It does include the oral stress-day dosing. The principles are very similar to DMD Care UK. The dosing are slightly different. We are in the process of aligning both. Myself, Hashini and Talat, who led on the BSPD guidance, are on the DMD Care UK working group. But it also now has specific inpatient and surgical recipes of what to manage nationally, which I think all hospital sites will now in time need to adopt to that, and will align that and also work with the emergency group and the app. And there's more information on the BSPD website if you're interested in that. We're also very interested to develop an educational online module on adrenal insufficiency, which patients can access to complement site training or as a refresher, for instance, or new staff, for instance, if you've got a new endocrine, or neuromuscular nurse, for instance, or a junior doctor. The issue of vamorolone, which will probably come into some shape or form, we hope in time. We want to issue a statement on vamorolone and adrenal insufficiency. Some or most of you who are aware of the publication know that adrenal insufficiency is present in vamorolone. We want to make a specific statement. Bear in mind that you know vamorolone, but if a patient attends the hospital, nobody would have heard of vamorolone. They might not have any idea. The same is of the Flazacort as well. Just be mindful of that. We also hear of patients and adolescents who are turning up to endocrine clinic, and certainly my personal experience in hearing from some of Alex's and patients' experiences, that they're not very prepared for pubertal assessment. It is an intimate examination. We want to develop an infographic which will at least help prepare such intimate examination, and that's our work for this next year. We have a bone health leaflet that should be finalized soon. Ross, myself, and Richard Keane, an adult rheumatologist in bone, will work on an adult management guideline of osteoporosis in adults with DMD. The DMD Care UK group will link with that project. The need for this guidance is because osteoporosis in adult is effectively guidelines and clinical pathways and evidence from older postmenopausal women. There is a large gap in young men with DMD. There are also at least about 2 to 3 more osteoporosis agents that can be used in adults that we can't use in children. That's completely not addressed in the 2018 International Standards of Care. In time, we will also develop a bone and endocrine monitoring for vamorolone, and we will also liaise with other working groups. So research is my last bit, and I just want to touch on that very briefly, but also let NorthStar colleagues know of some of the other research that the working group and myself have actually been developing with lots of other colleagues in the country. We've had some funding to develop a retrospective study of the vertebral fracture cascade in boys with Duchenne involving several other sites, but this also involved a qualitative component of interviews, and some of it face-to-face, some of it online, to identify the impact of fractures, particularly vertebral fractures, and quality of life, but also ask these families, particularly the adolescent boys as well, what they think about if we change care, particularly giving bisphosphonate a bit more proactively, for instance, before fracture. And finally, some of you might also know that the NIHR have actually put out a commission call on bisphosphonate in boys with Duchenne muscular dystrophy. It is work that we've been working together very closely in my engagement via the British Society of Paediatric Endocrinology Clinical Research Group with patient groups, including Alex as part of Duchenne UK from the start, for a commission called There are some core members of the research team already. We are very keen to also engage other NorthStar clinicians, particularly DMD hub site. And I believe that Michaela and I will send an email to people to attend a meeting just for us to give you a little bit more information. I think it's on the 30th of January at 1 p.m. 12, right? Okay.
You are not very good.
Okay. Final slide is that these are my own reflections, which I've actually mentioned yesterday. I think as we move forward towards care, developing standards of care, and as this project, I think we need to flip the pyramid to actually, at the point of developing standards of care, ask the patients first of what matters to them. Maybe annual MRI is too horrendous for us, but maybe it's not for the patients. I think we also need to introduce evidence-based and not just rely on expert consensus. And this is working in partnership together, looking at data, funding of research with patient groups, and also engaging academics might also be very useful. And I think I'm going to stop here.